This
They go through
conference will now be recorded.
And so one of the things that our team does moving as soon as they get hired on is they spend about a month going through specific trainings. Now, some of that training is town specific. They meet with law enforcement, they go in, they meet with all the different businesses in each of the towns. They go around to different community sites, get to know what's taking place where are kind of the hot spots in each community. And then what do we need to teach? What do we need to make sure that they're trained in order to be successful? They have about a 2-page long training module that they go through right now in order to be able to meet this many diverse needs across our towns. And this is just a very, very small example and kind of overview of some of the training that they do. So the purpose of this team is to really, how do they meet as many unmet social service needs as possible? Sometimes these needs are linked to mental health and substance use, and sometimes they're not. Sometimes they're linked to post-pension supports after there's been a tragic event in the community or with a family member. The purpose is really, what are the needs that aren't being met, and how do we meet those needs? And how do we need to flex ourselves around what's taking place out there to really provide that level of support? The goal is, of course, to try to be as proactive and preventative as possible to keep people from needing first responder services, which is the main reason why the team came about. Was, of course, law enforcement was having to work with many individuals in the community where really what they needed was somebody who had more of a mental health background to help support them during that time. What the team offers is immediate and community-based triage and outreach. They provide intervention for mental health, substance use, financial instability, post-pension services, homelessness. And one of the key factors when I mention homelessness that I think is really important to delineate here is we find that it's obviously a better situation to not have individuals become homeless in the first place, which means the team spends quite a bit of time trying to maintain people in their current housing situations. So they're having conflict with their neighbors, or they're not fulfilling what they need to in order to remain in the place that they're in. They're not paying their bills, or whatever the case might be that's putting their housing in jeopardy. The team works really closely with individuals to try to mitigate those issues that are coming up for them so that we can hopefully prevent them from becoming homeless in the first place. They also monitor, intervene, and prevent escalation and negative symptoms out in the community. So you think about somebody is in a coffee shop and they're starting to become escalated, and the community is kind of fearful, the shop owner is pretty upset. They're able to come in during those times and really try to figure out what's happening for this person. How do I help them? What is it that they need? What's going on for them? And how do I help create safety for the patrons that are at these businesses or at these different public sites, and also make sure that the business owners can, or the individuals who are working in the businesses, are able to maintain the services that they're attempting to provide. They de-escalate many situations, and then they offer referrals to resources and services. So Kevin's put me up to a greater challenge here because I honestly can't see half of my screen. So please be patient with me. I don't know how to use this format to have it stop covering. So I'm doing my best over here. But
you know, see your screen just fine, man.
I think you can all see it. The problem is I can't see the whole right side of it.
Okay.
It's behind. Can I move this whole thing? Oh, maybe if I move this there. No, I can't see the left side. If I hit the X, will it completely shut down the program?
I hope not.
Collapse? Are you all still there?
Yep, we're here.
Okay, great. I can't see any of you anymore, but I can see my screen, so hopefully this will help. So ways to access the team. Individuals can call the team themselves. It's one phone number, 488-7778. That phone number is is intentionally 1 digit off from first call for Chittenden County so that it's easy for members of the community to memorize. Also, community members can call us for somebody else that's in the community that they have concerns about. They're concerned that they need additional support. They're not sure what's going on with them. They see that they're struggling out there. So anybody in the community can contact us at all. Service providers call us, police call us, obviously, dispatchers, families, friends, merchants, any concerned member of the community or somebody's service and support team. And then the current hours of the team are Monday through Friday, 8:30 to 8. And as you can see here, we get quite a few calls. And this is from fiscal year 20's information. So we received 776 calls from law enforcement specifically. And the reason why that number is so high is that a number of the calls that come in, dispatch is able to determine who's the best suited to go out and manage that need. So as long as they've been able to determine safety of that situation that's being presented, the dispatcher is able to decide when it's going to be law enforcement versus when the team can make contact or when they need to go together to certain calls. And certainly officers also make that same call all the time. We have 252 calls that came in during fiscal year 20 from clients and community members, and then 182 from providers. And then you can see the community outreach staff account for 173. And what that is proactive calls. So say an individual is calling the fire department every Tuesday at 5 o'clock at night. The fire department can give us that information and we can start working with that individual ahead of time to figure out what's happening on Tuesday at 5 o'clock at night that's causing that individual to reach out to the fire department. Is there any services, supports that we can put in place to try to help that individual navigate and make sure that they're connecting to the right resources? Because the challenge is that many people call 911 or call first responder services because they know somebody has to answer. They know somebody has to provide some level of help. And so if we can figure out what it is, what need is not being met, then we can help serve that need and not overutilize those first responders. See, if we get 53 calls in fiscal year 20 in regards to the family, parents, guardians, friends. And then first call works really collaboratively with the team. We're going to talk a little bit about that in just a few minutes here. And then schools as well work with the team. Sometimes it's with SROs, sometimes it's not. But oftentimes what we really like to do in regards to the school piece is how do we become kind of a warm handoff from a kiddo, maybe a kiddo struggling in school that day, and they need more support as they transition back into the home. How can we be a part of that transition and success when they reach their home so that they don't go into further crisis? Here we go. I just wanted to share with you an example of our business guide. So every town that this team serves has a business guide that's made specific for their town. And these go up in each of the businesses so that the individuals there can get a better sense of what is it that community outreach can do. So they have the patron that's come in and they're escalated and people are really concerned about them. You know, this helps them determine what's a call to the police department versus what is a call to community outreach. And so I think this is just helpful to share so that people have a better understanding of what we're doing maybe behind the scenes. This isn't usually hanging where anybody entering the business would see it. It's usually behind the scenes so that they know, like up on their corkboard, so to speak, to know that here's another resource that we have to get our needs met. And again, a little bit more about the collaboration with the first responders. Yes, Diane, I can absolutely send this out to everybody. So one of our greatest charges is collaboration with the first responders. So again, the goal is how do we get people utilizing and accessing the supports that are the right supports at the right time for that individual. And it's often not law enforcement, even though that's an easy call because somebody will answer. And people are in crisis, people are struggling, and it's absolutely an emergency to them. It's just that they're not necessarily reaching the right group of individuals to serve that need. And then again, we work with fire and rescue, we work with EMTs, we work very collaboratively with all these teams. And then call for anybody who is not aware, First Call for Chittenden County is the crisis team that we have. I also oversee that team. And so these teams work really well and cohesively together, and the calls can go from either direction. So if First Call receives a call from somebody and we don't have a clinician immediately available to go out at that time, we're able to work with community outreach who's serving those 9 towns and say, hey, are you able to provide a little bit of extra support for this person at this time? The reason why that's important is because typically what would happen is we would have to recommend that somebody, if they couldn't remain safe or there was further concerns about their ability to be able to wait and not escalate even further during that time, we would have to send individuals to the emergency room, or we'd have to recommend that they go there. That's not the place that we want to send people. And so this works really well when we're able to help out. Or sometimes somebody's calling and they don't necessarily need a crisis clinician to come out, they just need support and outreach in general. And so First Call is able to contact community outreach to do that. And then on the flip side of that is if community outreach is out, they certainly have training in regards to working with suicidal individuals or homicidal individuals, but they are not trained to do the assessments to determine a level of care for inpatient or whether or not somebody may require a mental health warrant. And so if they're working with somebody and they're not able to de-escalate the situation enough, or they have concerns that the individual absolutely requires that higher level of a response and outreach, then they contact First Call and they work in tandem together to have that person be seen and to make sure that they're getting the supports that they need. So this is the big one, right? How does this all get paid for? So right now the towns pay, and these numbers are based off from fiscal year, up to, January 1st. And this is what the original 7 towns are paying into the program, and then how the remaining funding takes place. So we have a grant that goes through UVM-MC for $75,000 per year, and then Department of Mental Health has a grant with us for $160,000 per year, but the remaining amount comes from all of the towns. What I can tell you is we have added 2 more towns on, as I mentioned earlier, Milton and Heinsberg, and we've also added an additional position on in order to bring on the towns. And so with that, the town amounts have gone up, of course, to make sure that they cover the entire program, but the UVM-MC grant remains the same and the DMH grant remains the same. Here's our services by town. You know, originally I had some of the data from fiscal year 19 and then fiscal year 20, but I thought it was more important to highlight right now the difference. You know, fiscal year 21 is the second column here, and that's based on 6 months time frame. So if you look at those numbers of where we're at in the first 6 months, which wasn't as busy as what it has been these past 2 months, you can see that we are on trajectory for really exceeding the numbers of services that we had offered last fiscal year and provided last fiscal year. And this is our contact data. Again, I did fiscal year 20 and then fiscal year 21, the first 2 quarters. And I mean, total contacts, that number is pretty impressive, especially when you consider the fact that we are in COVID times and there are periods of time that we haven't been able to provide the same level of face-to-face that we might have previously. Now the team has been out there for several months now doing face-to-face work and contacts with individuals. They do COVID screens ahead of time, of course. Everybody has PPEs, but I think these numbers are pretty powerful when you think about that. We're basing this on 6 months versus a full previous year from last year. Volume 341 less than we had in the entire year last year is pretty significant. This team is very busy. And then our total face-to-face incidents over the first 6 months was 471, and then we served 464 unique clients. These are referrals. Our team does a significant number of referrals, as you can see, and that's the goal, right? Get people connected. And so the main categories of where they refer to are behavioral health services, physical health services, social services, and then first call. And this gives you a great insight into where those referrals are going to and what the needs are in our community. And I'm just sharing this to let you all know, this is part of a data report that I run for the teams every quarter. So these numbers get updated through each quarter and then on an annual basis as well. But it just gives you an idea of some of the information that we pull and share, partially for funders and partially for the program to know, are we really hitting the nail on the head? Are we meeting the needs of the community, and what does that look like? And I think one of the things that's really important, if you look about halfway down the page, there's police involved contacts, and that's a really important line item for us. So you can see there's 381 contacts where we assisted the police or we co-responded with the police, but there's 384 times where we were able to completely divert the police from needing to go out. And then the police resource time saved in hours was 33.4 hours. So what that means is maybe we've gone out and we've co-responded with law enforcement, but they're then able to leave the scene after a pretty short time frame. Maybe they've determined that the scene is safe and what's needed is not necessarily what an officer might be able to provide to them. And so then a community outreach specialist is able to stay on the scene and provide additional support to that person so that they can make sure that they're really getting the needs met. So it's not just kind of coming in, managing the crisis in that moment, and then needing to step out. It's really following that individual through, getting them connected. So the top issues that the team supports is behavioral and mental health concerns, and then family and relational conflict, homelessness, legal issues, and substance use. And then I wanted to end with another quote, which is, I've told other people in my building, have given cards to friends, grateful and thankful for the service and for being able to talk to specialists when needed. Things would have gone really bad without the service. It helped me through a very, very difficult time in my life. I hope this program gets the funding it needs as I consider it essential. And that was from a community member. And I know I can't see the time on my thing, but I think we're pretty close, and I hope we have time for maybe share.
Yeah, we have time for Rachel for maybe 5 minutes or so.
Hi, everyone. My name is Rachel Waller. I'm the team lead for the Community Outreach Program. I've been part of the team for about 3 years now. I joined on as a Community Outreach Specialist and then recently assumed my new role a few months ago. And so I'm going to touch on a couple of cases that kind of really highlight the work that our team has done, considering that, you know, a large goal of the program is to divert the overuse of first responders while simultaneously getting folks in the community set up with the real service that they need and addressing the root of the overuse or misutilization of first responders. So I can think of an individual who was calling the police department over and over and over again, articulating some pretty significant safety concerns. That individual was flagged for our team. I have a teammate who spent hours supporting this individual, kind of getting to the root of what they really needed, got her set up with kind of the full gamut of community support to the point where she has a full team now who supports her, and the safety concerns have dropped significantly. The multiple times a day calls to police that were involving police and rescue have decreased significantly. And there's also, I can think of an individual who had some, again, pretty significant mental health concerns that were brought to our attention by one of the local police departments. There was an overlap as well with some behavior that was considered criminal. However, the police recognized that it was really caused by this individual's unmet social service and mental health needs. They repeatedly called us to support her. One of the wonderful things that Brandy mentioned is that once a specialist arrives on scene, if we feel safe staying there, we can look at the officers and say, you know, hey, we're good, you're free to clear. And as long as they kind of agree with our assessment of the scene, they can go off and handle the other emergencies in their town while we spend as long as is needed with that individual. Through repeated contacts and building rapport with that individual, we got her to a point where she was able to kind of accept the resources that we were offering. Not everyone accepts it the first time around. The beautiful thing is, because we serve 9 towns, we'll often bump into individuals that may be new to a police department, but we might have been interacting with them for months or years. So we have a lot of that context and can kind of pick up where we left off. And that individual got the help they needed. Just to touch on another brief one, there was a family who was really, really struggling after the unexpected death of their child. And our team was able to support them for several days in a row, kind of not just with their immediate grief, but navigating all of the processes that a family has to kind of walk through while in their initial shock. And that was really helpful to them to have someone constantly there. And then we get all of the officers in our towns, and I think dispatchers as well, and you know, the admin above them, do a really fantastic job about identifying the individuals who, you know, for lack of time, for lack of, you know, not being as familiar with the resources as our team is, they're just not able to support that individual in the way that really gets them the help that they need. And the departments do a fantastic job of referring those individuals to us. The collaboration that we have, and there's several individuals, you know, in each of our towns where they'll still call into dispatch, but dispatch will recognize, you know, this person is calling about something that, you know, appears criminal, but, you know, based on our history and Outreach's history with them, we can identify that we can just patch that call through straight to Outreach. That saves officers a significant amount of time in terms of going out to the scene, you know, determining, you know, there's nothing for us to do here. And that's been wonderful as well. I'm not sure how I'm doing on time, Kevin.
I think you're fine, Rachel. Those are great examples. I wanted to see if one of the chiefs could talk about their side of that relationship with you and your team. One of our police chiefs who's here, or a police officer.
You want to take that, Pete?
Sure. For those who don't know me, and that's probably most of you, my name is Peter Hull. I'm with the Colchester Police Department, and I'm just going to speak briefly to you about the perspective from patrol and our interaction with the team and that relationship. I think that at this point in the game, we're 3 years into this program, that if this stopped, I would have a mutiny on my hands with my officers. You know, just the expertise that the outreach team brings to the table and the amount of time saved, I really don't know how you measure it. I think that the statistic that Brandy gave of the time saved at scenes is probably really low. I don't know how you measure that, but I think that just in the calls that we don't even know about and the follow-ups that the team does is significant. We have you know, a variety of levels of experience at our agency, and you know, I had some pretty cynical people when this program started, and as the relationships developed with the providers and they got to watch them perform and a trust built with the program, it has really changed how we look at a lot of these calls. And a lot of these calls really come to us that shouldn't. We will always respond because we're the entity that's always there, but they're really not looking for a police intervention. They're looking for a service and support, and outreach provides all of those things that an officer will not be able to. And if they do, it'll take significant amount of time and phone calls for them to figure out in what direction that the incident needs to go. You know, prior to this meeting, I queried my people with some antidotes about interventions, and two that really stood out to me were one in which a family had a health issue at home. There was an in-home healthcare provider, but there was also an adult family member who had significant mental health issues and was very upset and frustrated with the situation. And it really wasn't a police issue. And outreach was able to provide for that family services, give that healthcare provider relief, give the family relief. And I think after the initial call, I don't know that we've had any response to that resident, but I do know that outreach has gone several times and has continued to follow up with them. Another incident that we had, we have a lot of, our hotels are now housing an awful lot of people in the past year who have significant issues, and we spend a lot of time with those folks, and outreach does as well with economic services. And we had a male who was expressing suicidal and homicidal ideation, and really did not want the police to be there. The officer was concerned for the safety of the outreach person, but stood around the corner from the door where they could keep an eye on things, while that outreach person very skillfully de-escalated that individual, and to the point where that person was willing to get into a police car and go to the hospital, which was a significant hurdle for them. I think that the only other thing I'll tell you from the patrol perspective, as well as from a management perspective, is watching some of these folks practice their skill, and with the de-escalation, our officers are learning. They're seeing an example of how it should be done, and while the outreach team has saved us an awful lot of time, we still go to a large number of calls just because of the volume of calls that we get and the need in the community. And I think the skill level for some of my officers to de-escalate a situation and actually look at it from a much different perspective has increased a lot since this program has been on board. I don't know if anybody else has anything else to add.
Thanks, Pete. That helps a lot. We get both perspectives from the counselor standpoint and from the police perspective as well. Like to wrap this segment up, turn it over to a couple questions anybody might have until we move on to the next segment. Are there questions out there? If so, just speak up and announce who you are. All right. I want to thank our friends and our partners from Howard for this great overview, and Brandy is such a great team leader. I do want to end this segment and point out that the 9 communities are very happy to support this program financially. As you've heard, critically important services in our community. We are up to 9 now. The state appropriation has remained at $160,000. We would hope our legislative delegation would consider maybe bumping that up in recognition that we're now covering literally 16% of the state population with this program. So we'll follow up with our legislators about that. But I think now time to move on to the second item we wanted to talk about. And this involves people in our communities who quite frequently are presenting with both mental health and addiction issues. And it seems to kind of fall a little bit into a gap. We've got some experts on the call here today to talk about this, but I wanted to turn this over to Chief Burke to maybe define the issue a little bit better than I have.
Certainly, thank you, Kevin, and I appreciate everyone being on the call this afternoon. as you've heard, there's tremendous synergy between the police and Howard on this program that's going on. And it's not that the police want just simply out of this work. There's been so much down pressure on community-based resources for folks suffering with crisis that the overflow has naturally come via 911. The frustration that has fallen upon the police is our inability to meet those needs when we're called. It's simply a frustration. And when you cannot serve a community and leave its residents with their dignity, that's not a good place for the police to be. That's not why we do this work. And I will tell you, firsthand, and now leading a fairly good-sized police department here in Chittenden County, that the number of folks with the co-occurrence of some type of crisis issue compounded by substance use disorder has really accelerated. And you say, what does that look like? And I just have calendar year numbers here for South Burlington. We've done 248 mental health related calls, 173 intoxication calls, and 454 welfare checks just in calendar year 2020. And this is at a time when our call volume was suppressed by about 13% due to COVID. And what we're seeing are folks that fall through the gaps or fall into the gaps in our community-based resources, and particularly around the co-occurrence of substance use disorder and mental health. One challenge, I should back up. We took apart this a little bit with the Med Center over the last year, kind of gave it an operational autopsy, and we came up with 3 areas of concern from our exploration of this. And that's Vermont's interpretation of the DSM-5 does not include substance abuse disorder as a major mental illness. So oftentimes when we're able to coax someone up to the ED, which is always last resort, or we have to rely on applying for, or Howard applies for, a warrant for an emergency evaluation of a person. Once they're brought up to the emergency room, if there's any evidence of substance use disorder, quickly their behavior is explained away with that, and they're subsequently just spun back out on the street, which is doing nothing for them and really complicating things from an operations perspective for both the community outreach team and for law enforcement. If a person goes to the ED, our second point, if a person goes to the ED and they're actually evaluated, they're evaluated by 2 clinicians. And I don't question that, law enforcement doesn't question that whatsoever. But what is odd is that the first assessment is fully informed by everything that happened on the street, maybe what's outlined in the affidavit, maybe there's a sidebar conversation with the officer or the team that has brought this neighbor to the ED. A decision is made as to whether or not that person needs to be hospitalized, and then a second clinician is brought in sometime later after the person has been stabilized in the emergency department, and an independent evaluation is done. An evaluation, as I understand it, that is in no way informed by the first. And oftentimes we'll see again this person immediately flushed back out into the street with little to no supports, perhaps falling into that crevice that we just picked them up out of. And we're left with trying to, again, help this person. But even with the community outreach team, there are no resources available for that person. Lastly, the state of Vermont does not have a physical space for those suffering with issues that are related to a traumatic brain injury or developmental disorder, who have eroded to a point where they either are a danger to themselves or others. So much like with co-occurring substance use disorder and mental health crisis, the police are getting involved once a person has degraded so much where they're a danger to themselves or others. These are calls that after we've had the person to the emergency room several times, after we've had the community outreach team trying to support them in the community, that have called us begging us, come over here and kill me, come over here and shoot me. Those aren't the things that the police want to hear. Those are not the incidents that we want to respond to. And I feel as though if we were to look at this and the downward pressure that we saw post 2015 on the system as the boom, right, the explosion, if we look left of that, there has to be intersect points where we can better serve these Vermonters. And now we're completely focused on the right, trying to catch up to the damage that's already been done. So I think this is a really complicated equation that we're trying to help you folks help us with, I should say. But it's extremely frustrating, and it's not the police are upset or angry or don't want to do this work. We want to serve our neighbors with dignity. We want to bring them to a resource, but we're really at a vexing moment in this. And we're not even talking about the small percentage of the population that are completely treatment resistant. We're talking about people that will actually respond to some level of treatment, but when they're left to themselves for too long in the street, they degrade quickly and find themselves in a very dangerous position. So just real quickly, 2 of these cases in 2020 degraded to a point where we had a young woman living on Dorset Street in a CHT complex. Her behavior was much as I described, in and out of the emergency room, a lot of contact with community outreach. She actually set her apartment building on fire once. That wasn't quite enough to get her held. And this went on and on and on until she met this criteria. Similar fashion, a male subject kept calling us, begging us to kill him, trying to instigate us into having a lethal force encounter with him, was seen several times at the emergency room, didn't meet the criteria, went on to then try to light the city hall on fire in Burlington. So these things are very serious incidents, and we feel as though that this group can give them the attention that they deserve. Thanks, Kevin.
Thank you, Chief. Thank you very much for kind of outlining, giving perspective on this. This part of the meeting was intended to be a roundtable. We have medical professionals and others on this call who may want to weigh in and validate this issue or argue against the reality of this. But if you have a perspective on this section, people co-presenting, please speak up, because as the chief noted, we need to move toward a solution because too many people are falling between the gap here. Any folks out there, turn your mic on and just speak up.
Yes, this is Representative Sarita Austin from Colchester. I'm just wondering, do these people get into treatment and are followed up, so they're treated for their mental illness or substance abuse, or is it just that you come in and help them at the moment and then they go back to the situation, that they were in?
I think what the chief is, go ahead, Chief.
I don't want to consume all the bandwidth here, but I think that there's a lot of layers to that. So pre-COVID, we could make some referrals to substance abuse court, and sometimes through the structure of that, people could find success, but a lot of that work hasn't been going on. I think some people find varying levels of success of being connected to either first call or community outreach or some combination, or community outreach just orients them back to what was working for them previously. But with these other folks that really degrade, they're in a dangerous spot, and they're not responsive to what we have, the normal rabbit in the hat, if you will. And I think there needs to be more thought about that from folks learned in how to serve people in crisis, about what else are we missing in terms of community-based resources to try to better serve these folks so they don't degrade to these points.
Thanks, Chief. Morning Fox is with us from the Department of Mental Health. Morning, please weigh in.
Thank you. So a couple of things. I just wanted to touch on some of what Chief Burke was saying. Just to be clear, Vermont doesn't have a different interpretation of the DSM-5 than other places. The DSM-5 is a manual that includes a vast array of syndromes and disorders. Substance abuse across the country, in fact, many nations, is not seen as a major mental illness per se. There are states within our country that have involuntary commitment laws for substance abuse. Vermont happens to not be one of them. I used to work in Massachusetts, where I actually ran a 40-bed inpatient facility for women who are involuntarily committed under Section 35 in Massachusetts. for treatment. And so I just want to be clear that Vermont there's no specific, Vermont has decided that those things do not equate major mental illness. And so when we're talking about things like substance abuse or something of that sort, there are avenues. But Vermont and the legislature and the statutes in the state take a lot of pride in the voluntary nature of our treatment service system. And so when we start talking about involuntary treatment of individuals, similar to incarceration, you're taking away people's civil rights. And so Vermont has a very high standard for looking at involuntary treatment. Not to mention a lot of research around the efficacy of involuntary treatment does not hold up nearly as well as it does for voluntary treatment. And I would say that, we had many repeat involuntary folks in the substance abuse world in Massachusetts when I worked there over my time there. I had a question for Chief Burke. I was just a little unclear on the second evaluation that you were referring to, Chief, or if you're talking about in the involuntary process, having the screener and the doctor doing evaluations. Is that what you're referring to?
Yeah, it was similar to the conversation that we had some months ago about this process and just trying to better understand it. And again, I agree with you about involuntary commitment. I don't think that that's a place where this needs to go, but I do think that, in looking left of the boom, that there has to be some opportunities that we can leverage.
And I completely agree. And I think what part of what we need to look at is how do we integrate a lot of our services. That's one thing that Vermont has done, is that it's really separated, even within our own agency, the divisions around alcohol and drug, developmental intellectual disabilities, TBIs, and mental health. You look at other states, it's not always divided that way. In fact, Vermont used to be the Department of Mental Health and Developmental Services was one integrated department. And so I think part of what we're talking about here, we're talking about officers bringing someone in who may have mental health needs or may have substance abuse needs, or both, or developmental and substance, et cetera, and kind of that combination. It's really hard in those moments to try and discern the dotted line from the problematic behavior in the community to, was it caused by the addiction? Was it caused by the developmental issue? Was it caused by the mental health issue, et cetera? And I think the better we are as a system at trying to integrate and having kind of support systems together, I think we're going to be moving in a much better place. Because right now does this person go to assist? Does this person go to Act 1? Does this person go to, some other, type thing? And so what ends up happening is law enforcement is left kind of struggling with that. They're in the ED, then that struggle continues there. Whereas if we have more kind of an integrated approach, then I think we're looking at less doors means, quicker access to those supports when you have kind of that decision-making process. I think one of the things we're trying to do is trying to keep people linked into those systems. We're looking at, one of the things we're trying to do is taking some money that we're hoping the legislature will pass for us around justice reinvestment, which would help coordinate actual mental health and substance abuse treatment services for people who are connected with the criminal justice system through probation and parole and such like that, and really trying to increase the collaborative nature of the work between those two systems. And so I think a big part of the work we have is as all of us together, and clearly this is important work. We have 50 people on the call here today, and I will sing the praises of the outreach team as much or more than anyone on the call. And people who know me know that I'm a great supporter of kind of the integration of mental health and addictions and developmental work with law enforcement. I've been a long-term advocate of people who go into law enforcement did not intend to be social workers necessarily. that is become a part of your role, and you are a social service, but you didn't go to school to be a social worker or to be a therapist, etc. Thus, you know, as folks were talking earlier, just being around and working with folks from the community outreach team and kind of seeing how they interact with folks, that type of marriage and learning from each other is a huge thing. That's why I'm also a big proponent of, you know, the embedded, having the embedded mental health clinicians with the state police. You know, I think it's a great learning process for all those people who are involved, because it always adds one more tool to our toolbox. But I'll stop speaking because I don't want to use up, you know, take up all the bandwidth. But I think a big part of it is integration of those services. Is a direction I think we need to head.
Where does that stand, would you say, Morning? If it sounds like the integration of services is where the chief was really heading. Can you tell us how that is moving forward with integrating those services? What's the future there, and when?
Well, I think there's a lot of that happening in various pockets, and I think that's one of the struggles that we have as our state, is that we have some things that work really well, say in Chittenden County, community outreach being one example of a greatly kind of integrated service. That same model doesn't necessarily work in the Northeast Kingdom, and so we have very different pockets of our state in that sense. You know, I think that's just how we need to start looking at it. Is how do we integrate pieces and learning from each other. You know, personally, I would love to see some of the different things kind of growing out of this in the future. Different places for law enforcement to bring folks. You know, similar to having calls, having call centers and 911 call centers knowing how to divert a call straight to community outreach, I think is one of the first steps that needed to happen, and kind of that understanding of this doesn't have to be a law enforcement response. And so I think it's that type of work that we need to continue to do, is kind of, you know, different models of crisis bed facilities, different models of hospital diversion type programs. What we have, I have no problems with, no qualms, and they have their place, and they're excellent. It doesn't mean that we don't also need some other tools and other types of places like that.
Well, we're going to talk about another tool here shortly, but who would drive the discussion about the integration issues, Morning? Is that a legislative discussion? Is that an agency discussion? How can we be involved? How can we push that forward? Because the issues that the chief talks about are real, as you know, and we'd like to see that move forward.
I would say yes to both. You know, I think, you know, from an agency perspective, taking a look at how we operate, what pieces of the work can be shared, and you know, things of that sort. I see some folks chiming in on the chat, and you know, it's exactly where I was going, is that there are kind of different states have things like alternate emergency rooms, if you will, and you know, alternate places that are staffed with a myriad of professionals. That, you know, it's not just staffed with mental health professionals, but it's staffed with addiction specialists. It's staffed with folks who work with developmental or intellectual disabilities, or, you know, TBIs, and you know, you have this kind of blending of work together. And I was having an interesting conversation earlier today with one of the state's attorneys around licensed alcohol and drug counselors, and the fact that, you know, a psychologist or a licensed, you know, clinical mental health counselor, et cetera, can also treat addictions. It's not that they can't. And so, you know, it's based on skills and scope of knowledge and things of that sort. And so I think there's a lot of those pieces. Do we have the personnel resources in the state to be able to staff, you know, other facilities, you know, like what we're talking about? or are we kind of at our carrying capacity and need to look at more integrating of what we currently have versus standing up new and different things? So I think there's some study that needs to happen to figure out exactly what will work for Vermont, because what works in Massachusetts is not necessarily going to work here, and what works here won't necessarily work in California.
Okay. Any other comments or thoughts about this subject before we move on? So please turn your mic on and speak up. Diane, you turned your mic
Hi,
on.
Kevin. It's Diane Bugby.
Yep.
I just wanted to say that, oh, sorry, can you hear me now?
Yes.
Can you hear me?
Yes.
Okay. So I'm a clinical social worker. I'm an engaged community member of South Burlington, and I have a family member that has struggled with a significant mental illness. And in our experience, the threshold to get help in Vermont is so high and requires a level of deterioration that puts families in an incredible situation where we can't get help. And what ends up is that the last call, the default person or people that we can call is really the police department. That's not their level of expertise. We have been treated with nothing but dignity and professionalism by our police department, but that's really not their role. And so what I struggle with is, and this is just our experience. We cannot speak for everybody, but the threshold of dangerousness to self or others is so high that getting help early is very difficult. And I think all of us that work in, professional social work and other fields know that early intervention makes a difference. We don't wait till someone, with cancer is at stage 4 or till someone has several heart attacks before we do, a coronary artery bypass surgery. We need to intervene early. We need to have options where we can get people help early on and not wait till things are so difficult for the individual and the family that intervening makes everything more difficult for that person, for the family, and for the community. So I just wanted to share that. Thank you.
Thank you. Thank you, Diane. If there are no, Helen.
Yeah, I just wanted to kind of note that sometimes these issues can also be addressed through a public-private partnership. And I'm thinking of the hospitals or private practices, and I just think that has a lot of opportunity, and they need to be at the table. If one of the issues is at the emergency room, then maybe we need to have the hospital or the emergency department in this conversation, and maybe I'm missing it. I don't know. There may be someone in that capacity. I don't recognize all the names, but to me, that's an important component. And
Well,
maybe that's a place where the legislature can, dig into this and ask them to present information. But they need to work in our community as well.
Thank you, Helen. We're fortunate that Isabel Desjardins is with us today, the medical director at the hospital, and knowledgeable about these issues as well. Let's move on to the last subject, which Morning has already kind of teed up for us, and which a member of the public has written me. I won't say who it was, but I believe we need a place where people can go where they can be safe and stabilized that isn't necessarily a hospital. Again, back to Morning's point. People can put themselves and others in harm's way and require support and intervention when they meet criteria for hospitalization and when they don't. So I think this is a continuing issue for our police, I know. And Sean, did we have any of our chiefs that wanted to speak to this issue?
I think Chief Allen can.
Great. Go ahead, Doug.
Yeah, I wasn't prepared for that, Chief Burke. Thank you, but it's a frustrating situation that we find ourselves in repeatedly. That there just doesn't appear to be that place that we can go, with these folks. It's to Morning's point where he talks about alternatives and that kind of thing. Those are in place when we talked about the outreach program, and to divert calls away from that is certainly our goal, but we often don't get that kind of information. It's often a crisis. It is the unknown. It is a sudden disturbance at a hotel or a restaurant or a convenience store that we respond to, but that once we have someone and outreach is not a possibility and first call is not, then we have to locate some kind of facility. And that codependency, that the problems that Sean talked about earlier, where we've got someone in mental health crisis and someone with a substance abuse issue, the location of where we take that person becomes very difficult. I know ACT, we've spoken with ACT on a number of occasions, and certainly since the pandemic, their beds are very limited in what we can do.
So Doug, would you say that a place, as was noted by a community member, where people can go that is secure, that allows people to some de-escalation to occur? These are not necessarily people that would make it through an emergency evaluation at the emergency department, but still are in need of some help and treatment, either for the addiction side or the mental health side. We need that additional place to go.
That additional step would certainly help us. I think we have seen, and my other chiefs as well, that at times that we take someone for assistance, that we're trying to get them some kind of assistance. Frequently they will beat us back to the community from us bringing them to the hospital emergency room. The ER is a very busy place. They are often the folks are not in a room. They're stacked in a hallway. They're not receiving the treatment that they're maybe needing. So that kind of step would certainly be a help to us, Kevin.
Okay. This is not an easy nut to crack, because it does need to be secure, not only for the individuals who go there, but also for the staff who are working there. But it just seems that we as a society are letting too many people fall between the cracks. Our professionals are understanding that a place to take somebody perhaps short of the emergency department, and not necessarily to Act One, is badly needed in our community. And so we're looking in this roundtable portion of the meeting for solutions and how we move forward. Does anybody else have some thoughts about this issue?
Hey, Kevin, this is Ron Hogue with Essex PD.
Go, Ron.
Hey, so I just wanted to add in there and just kind of echo a little bit of what Chief Allen and Chief Burke and Diane, in fact, I think they're just expressing the frustration that we see from our line officers when we consistently deal with the same issue over and over and over again with the same person. And it seems like there needs to be a process for an intervention in there at an early point, so we don't get to the point where someone is trying to burn their room down in an apartment building. In Vermont, we can take someone who is incapacitated via alcohol and bring them to Act One, where they can be stabilized and then receive treatment. But we can't do the same thing for someone experiencing mental health. They'll be released. So there's got to be an answer there. The other thing that I would say is that even with people who want voluntarily to get help, we recently have had a gentleman in our town that we have dealt with over 30 times in the last 2 months, including 20 times since December 1st. And he has consistently been asking to go to some type of structured place where he can get help. There are no beds for that person. I believe finally he's been moved out of Essex. He may have been moved into one of the other towns now, so we haven't had any contact with him. But it takes consistent, almost every day of having to address those issues with those types of people to finally get that, get something where that person can get stabilized. So there's got to be a better answer there.
Thanks, Ron. Any of our professionals on the call have any perspective on this? We do know that the emergency department has a backlog. They only have so much capacity. Yet we still have members of the public who need help. Anybody?
I'll weigh in just a little bit. My name is Peter Jackson. I'm an addiction psychiatrist at UVM, and grateful to see a couple of my other colleagues on here. There are mechanisms by which this is done in other areas, sort of something short of the emergency room, but that's still staffed with professionals to provide support. I think that's I think easier said than done, and it requires a significant amount of training and a significant amount of staffing, because you're sort of deciding how to meet that middle ground, whether somebody's safe enough to be in that situation. And so often I spend part of my time working in Plattsburgh within the network. Often there, sometimes people will be in the hospital emergency room and initially getting an assessment that says, well, we don't think they need completely involuntary treatment to be forced to hospitalization, but there is a crisis intervention center in Malone where people can sometimes go. It's not an emergency room, it's not an inpatient psychiatric unit, but it's sort of that middle option. I guess the other thing that I would weigh in about, and I'm sure preaching to the choir, because the people that are making time to be on this call are the right people that are involved. But when somebody is taken into the emergency room, when somebody is approached with a substance use disorder or a mental health condition, it requires a lot of training to navigate that appropriately. I'm so glad to, I would also be someone that sings the praises of the community outreach team through Howard Center, who's I have collaborated with them and had patients that we work with them. But it's something similar to that in a more structured setting. It's similar. It's a similar idea that you're having, but it's actually a location where somebody can go as opposed to a person going with them. I think that a huge gap in our healthcare system and in our community systems is just that these individuals are not treated with compassion, and that leads to them to not want to go. They don't want to go somewhere where they're treated like a second-class citizen. They don't want to go somewhere where they're stigmatized even further because of their substance use problems. And so it's again, I'm preaching to the choir here, but it's a broad training that we need more and more and more and more of, in my mind, is how do we treat these people with compassion and with respect? How do we help them regardless of what condition they're struggling with? And as other people have mentioned, I would just echo the idea that these are not and/or conditions. Substance use and mental health treatment are not and/or conditions. It doesn't come from one or the other when somebody's struggling. They're dual conditions. And any programs or policies or practice that we can emphasize where they are treated at the same time in concurrence is the right way to go.
Peter, you mentioned the Malone Crisis Center. Do you have do any other places like that, crisis centers in other states, all come to mind that we could we could do some research around?
I don't know if my colleagues have other examples. The other subset that I've practiced in several different states, including Michigan and Massachusetts, is having a little bit of a separate, just even a separate space where people can go. The emergency room is not a relaxing place.
Right.
And so that in of itself, I've worked in several institutions where, and somebody mentioned this in the comments, but several places where somebody who's there with a mental health crisis is not in the room next to somebody who's having a medical crisis with bells and whistles and alarms going off and people rushing in and out. But I don't know of any other local examples to give you as far as research goes. I don't know if any of the other physicians and my colleagues on the call do.
Any other input? Again, this is designed to be a roundtable.
Kevin, Chief
Yes.
Foley.
Hi,
Chief
this
Foley
is
from Williston. And I think what we got to get away from is that mental health and drug addiction is not a 9 to 5 problem. And at 8 o'clock, 9 o'clock at night, when everybody goes home, our only alternative is the emergency room, dealing with these people with the substance abuse and mental health. So again, we got to find some other areas to have a resource rather than just take them right up to the emergency room. Again, and then we have to tie up an officer the time before they get seen by the physician. So that's what my concern is that at 10 o'clock at night or 2 o'clock in the morning, when we have a crisis situation here in Williston, is that our only alternative is take them to the emergency room if we can get them to go.
Yeah, thanks, Chief. And I think all too often some of those trips end up at the correctional facility, do they not?
True.
And again, not necessarily the best place for our residents and our neighbors to be going with these situations.
Kevin?
Yes.
This is Catherine Simonson. Wanted to be sure everybody had a chance to weigh in. I would just share an observation that there actually, we do have a 24/7 program, Act One, and for folks who are publicly intoxicated, and there's also a detox program there that's used heavily. It's true during COVID we've had to decrease our occupancy to keep everyone safe. No one can share a room for understandable reasons. We also have a crisis stabilization program. I'm not familiar with a Malone program, but it's important for people on this call to know there is a crisis stabilization program for adults called the Assist program, 6 beds, and is also at capacity most of the time. My observation is that I think the needs in our community probably outpace our current resources as it relates to these 24/7 options, if you will, for folks who are in either a mental health or a substance use disorder crisis. There's certainly folks they're not able to serve by the capacity of the program, but I think the need is greater than what we have right now. But I do want to make sure folks know that rather than having no options, there are options. I don't know that they're sufficient for the need that's out there.
Thanks, Catherine. Other comments? Perspectives?
Yeah, this is Brady Heward.
Go ahead, Brady.
Yeah, I'm also a psychiatrist at UVM, along with Peter Jackson, and I think, and also an addiction psychiatrist. And I think these programs are excellent programs, like the Assist program and the Act One. Another thing that I'll mention is these programs are generally pretty short term, and the same can be said of the Malone Crisis Center. They're like 7 to 10 day programs, and like the example given by the Essex Police Department, I can't remember the chief's name, I apologize, but like these are temporary fixes for some of these individuals that need long-term care, and I think we can try to work on stabilizing but there also is that gap of what we do after that. And I know that Howard does an excellent job. UVM is involved with some of these patients, but Howard does an excellent job of taking care of the chronically mentally ill. But this is an issue not just that our community's really struggling with. I think this is a universal problem around the country. And how do we help these individuals, and how do we show that compassion and provide them with long-term care, especially when we want to respect their autonomy. And I'll leave it at that. It is a challenge.
Mm-hmm. Thank you, Brady. Other comments, anything from our legislators or other questions? We have a few minutes left before we're done. Yes, Jesse.
Thanks, Kevin. My name is Jesse Baker. I'm the city manager in Winooski. And one of the things I wanted to comment on today was one of the reasons the city managers wanted to convene this meeting is that we are seeing this as these challenges growing in our community. And these aren't these people to us. These are our neighbors. These are our family members, our children in our schools, parents in our Boy Scouts and Girl Scouts troops, et cetera. I think as a community, as a manager community, as a community of communities in Chittenden County, we've made a lot of strides to integrate services through Howard Mental Health and the community outreach team in our police departments, and we're eager to do that with additional partners, and eager to do that to solve some of these more immediate and long-term needs. So as our providers, as UVMMC, as CHCB, as Howard Center are taking up these questions, as the agency is looking at how to best integrate, we would really like to have a seat at that table so our neighbors are best served and so our communities can be as strong as possible. So I hope that as these conversations keep going in different venues, we as neighborhood leaders in our communities can help be a part of those conversations and have a seat at that table. Thank you.
Thanks, Jesse. And Jesse is speaking for all the managers when she makes those comments. Thank you. Other comments or questions? From anybody? Well, we're close to our ending time. I'll leave it out there for a moment longer if anybody has any questions or comments to end with. But I see some areas where we need to work. We need to work on the integration issues that Maureen talked about. We need to look at expanding, perhaps expanding the facility that already exists through Catherine Simonson's comments. It seems that we clearly need additional capacity in the system. And we're all going to have to work together on that. I liked Helen's public-private partnership concept as well. So there may be other partners out there who we're just not getting to. Any final thoughts?
I'd just like to add,
Morning.
I'd like to just add one other piece as we're thinking about different stakeholders and other folks to engage in this conversation, that those in the peer community, Vermont psychiatric survivors, recovery coaches, and the recovery centers, things of that sort. I think they're a valuable resource, both as far as knowledge base and understanding of the issues, and as well as, just like I had mentioned earlier, staffing and who can be where and such like that, it's a matter of not necessarily, having the exact right letters after your name necessarily, so much as having the scope and knowledge base as well, especially when you're talking about kind of brief crisis intervention type work and, things of that sort. So I just wouldn't want to lose sight of including those folks in the conversations.
Okay, thanks, Maureen. Good catch. Good catch. Any last comments before we wrap up 5 minutes early? I really do want to thank the legislators who came tonight. I know you're very, very busy, and operating the way you are virtually and so on is difficult, but such an important issue for all of us. And I know we all want to try to do our best to do better, and we have to also recognize and all the great things that community outreach, Howard and University of Vermont Medical Center and others are already doing. That's a victory. So with that, I think we'll call tonight, and I think you're going to be hearing legislators and agency folks going to be hearing some more from us as we wrap up and talk about what we've learned tonight. Thank you all.
Nice job, Kevin. Brandy.
Thanks, Evan.
All my manager friends who are leaving quickly.
See you, Evan.
Thanks
Bye.
for pulling this together.
Very welcome.
All right, have that glass of wine. It's well deserved.
Thank you, Evan. Is that your prescription for the night?
It's usually my prescription. Have a good night. See ya.
Okay, you too.